2 minutes of discussion.
Yeah.
Dr. Sonwani, please.
Yeah, first of all, good morning, everyone. Good morning, Chairperson, and thank you so much for having me here and giving me this opportunity. Today, I'm going to talk about transcatheter aortic valve, past, present, and future, and I'll give a summarized conclusion, what is the current status of TAVR and what the guidelines says. We all know the background. The incidence and prevalence of aortic stenosis is 1 to 2% in the age 60 to 70. In 70 to 80, it is almost 4%, and more than 80, it is as high as 10%. And every decade, the incidence of aortic stenosis doubles. We know that the moment the symptom starts in aortic stenosis, there is a rapid downhill course, and the average survival is 2 to 4 years, depending on the patient is having dyspnea, syncope, or angina. At the same time, we also know if you treat this patient timely, the 5-year survival rate is as high as 90 to 95%. So why there is a need of TAVI in aortic stenosis? If you see, around 1/3 of the patient, 20 to 40% of the patient with severe aortic stenosis in real-world scenario are deemed unsuitable for surgery. And out of that, 50 to 70% they die within 2 years. Acquired AS is increasing along with multiple comorbidities nowadays, and elderly patients are scared and reluctant after surgical aortic valve risk counseling. People nowadays prefer and demand minimally invasive techniques, local anesthesia, and rapid discharge. So what are the evidences we are having for TAVR? As we all know, the first in man, the pioneering work was done by Professor Alan Kriebier in April 2002, and since then the journey of TAVR has started. I divide TAVR journey from 2002 to 2040, it is a past of TAVR, in which our aim was to establish TAVR as a therapy for aortic stenosis. So we enrolled more than 10,000 patients in clinical trial, out of which 5,000 were randomized, and we designed a trial called partner trial. We enrolled the patients who were extremely high risk and inoperable with surgical aortic valve replacement. And what we got the results, the TAVR compared to the patient who has not been offered any therapy or medical therapy, there's a significant mortality reduction. At the same time, when you compared with high-risk patient with surgical aortic valve replacement, all-cause mortality was similar. So the Partner 1 trial has established the TAVR and proves that the TAVR has improved survival in an inoperable patient, and it is an alternative to surgical aortic valve replacement in high-risk patients. During the same era, 2004 to 2014, the another platform, self-expandable platform, was also enrolling patients for clinical trial. They also enrolled more than 9,000 patients randomized in clinical trial, and the CoreValve study, which enrolled extreme high risk and high-risk patient for surgical aortic valve replacement. And that trial has really made a change in the journey of TAVR. The TAVR has proven to be superior to surgical aortic valve replacement in extreme high risk and prohibitive risk as well as high risk patients. Though the trial was started with non-inferiority trial, it has proven to be superior. And the guidelines were updated in 2017. So TAVR got class 1A indication in prohibitive risk for surgical aortic valve replacement. In high risk also, the TAVR got class 1A indication. During the same era, we learned a lot of things, which patient to treat and which patient not to treat. Extremely frail patient, dementic patient, they're better go with medical therapy. But severe COPD, cirrhosis, tumors, porcelain aorta, hostile chest, Rima-Lima anatomy, these are the good candidates where the TAVR has an upper edge over surgical aortic valve replacement. During this era, we also learned the heart team approach, which comprises the nurse coordinator, intervention cardiologist, CVTS surgeon, cardiologist, anesthetist, radiologist, and consultant physician, and a social worker. We all should have a patient-centric approach, and this heart team approach was also recommended as class 1C recommendation. So during era of 2014 to 2019, so there was a rapid evolution in technique, TAVR devices, and population. The devices are having more skirts, so the PVL has gone down. The sheath size, which was 24 French, 22 French to begin with, has come down to 14 French. And even the population, we started moving towards less risk population compared to high risk and extremely high risk population. We also started moving beyond the traditional risk models like STS and Euroscore. We are developing many TAVR specific risk scores and based on the CT imagings. So with the evolution in devices, we started enrolling patients who are intermediate risk for surgical aortic valve replacement. And the Partner 2 trial was designed with SAPIEN 3 device, and it showed the all-cause mortality at 1 year is lesser compared to surgical aortic valve replacement, but it was not statistically significant. And for the intermediate risk, the TAVR has got class 2A indication compared to surgical aortic valve replacement. So in 2017, what the guidelines says, the TAVR is class 1 indication for prohibitive surgical risk. TAVR is also a class 1 indication for high surgical risk patients. And in intermediate risk, the TAVR is class 2A indication. But with CERTAVI data, definitely the TAVR can become a class 1 indication. So we achieved our aims in prohibitive risk, high risk, and intermediate risk. What is next? The next was low risk group, which comprises almost 70% of the patients. So in 2019 to Future of TAVR, we started enrolling patients and planned our trials for patients who are low risk for surgical aortic valve replacement. And the Partner 3 trial with balloon expandable platform and CoreValve evaluate trial for low risk patients was designed. And the results were really, really encouraging. If you see, the 1 year, all mortalities, stroke, and rehospitalization was significantly lower compared to surgical aortic valve replacement compared to TAVR. And if you see, the trial was again designed to be non-inferior trial, but trial proven to be superior to surgical aortic valve replacement. If you see, the all-cause mortality at 1 year is only 1% in TAVR group compared to 2.5% in surgical aortic valve replacement group. The all stroke at 1 year is only 1.2% in TAVR group compared to 3.1% in surgical aortic valve replacement group, even in low risk. TAVR has consistently been proven to have a better hemodynamics compared to surgical aortic valve replacement, and the gradients are low, and there is a good effect to orifice area in all the trials which has been done from Partner 1 to Partner 3. So what is the status in 2022? The FDA was approved for high-risk patient, intermediate risk patient, and now even in 2020, the FDA has approved TAVR therapy for low-risk patients. There are a lot of future trials which are going on for early TAVR trial in which the asymptomatic patient, mind it, all the trials which has been done so far for severe symptomatic aortic stenosis patient. Now the patients are like early TAVR, we can enroll the patient who are asymptomatic but critical aortic stenosis, we can subject them to stress test and treat them with TAVR or to wait. There is another trial which is going on, TAVR Unload, in which even a moderate aortic stenosis with LV dysfunction patient with CAD, we can enroll and we can treat them and unload the ventricular load. The major game changer for TAVR is the Indian devices which has come into the market. There are a lot of devices coming into the picture in future like Accurate Neo, JenaValve, MyValve, Portigo, but there are Indian devices like HydraValve, which is the first self-expandable technology. The cost is a major concern for our country, and these valves and these technologies can definitely make this therapy more reachable to more and more our patients. So in order to conclude, the TAVR is now FDA-approved therapy for intermediate, high-risk, as well as low-risk patient in severe aortic stenosis patient. It has also been approved for valve-in-valve therapy with bioprosthetic valve failure, either with stenotic or regurgitant. The rapid evolution has really contributed to improved outcomes in TAVR therapy. The minimalistic approach and conscious sedation and early recovery is the way forward for the medical therapy. The trials are going on for bicuspid, aortic valve, as well as with newer devices. The first TAVR, if I remember correctly, which was done in February 2011, and currently we have crossed almost more than 1,000 to 1,500 TAVRs till date. There's still needs of a lot of training and understanding of this therapy, and so that it can reach to many centers as well as many parts of the country. If I want to just finish my talk with the future of transcatheter valve therapies 2025, the structural heart disease is an exciting new playground for every one of us. If we enhance the heart team model by showing mutual respect and improved collaboration, we all will succeed. But if the behavior turns territorial and antagonistic, this field will stumble and our patient will suffer the consequence. Thank you for your patient hearing.
Thank you, Doctor. Available in India.
Yes.
How, in your clinical practice, how do you choose between these valves?
Excellent question, Doctor. Basically, 60 to 70% of anatomies are suitable for all the valves. But 20 to 30% of the anatomies where you really need to have and decide the technology whether balloon expandable is better or a self-expandable is better. If the anatomies are like bicuspid anatomies, heavily calcified anatomies with a fused rapid type 1, heavily calcified, these anatomies, the rapid don't yield. So the self-expandable platforms are not a good option in this kind of patients. In this kind of patient, the balloon expandable are much better. If there is an annular calcium, LVOT calcium, there is a huge risk of annulus rupture of LVOT rupture. In those anatomies, the self-expandable has more upper edge compared to the balloon expandable. If the coronary heights are compromised and low, and sinuses are not very wide, in my opinion, the self-expandable platforms are not really good options because there is a more difficulty to engage those coronaries in future, as well as if there is a occlusion to engage during the procedure is also more difficult. In balloon expandable platform, it is an open cell design which is 50 to 60% is open cell design on the top side. So even if you occlude, the re-engaging the coronary will be much easier, and even the future coronary interventions will be much easier. But the self-expandable platform, which will definitely have an upper edge in small annulus size, any annulus size less than 23, I think the self-expandable platform has an upper edge over a balloon expandable platform because there is a patient prosthesis mismatch is relatively lesser in self-expandable platform compared to balloon expandable platform. The valve-in-valve anatomies, upfront, the valve-in-valve anatomies, the true ID is much smaller than the valve which has been put by the surgeon. So the self-expandable platform is always superior to balloon expandable platform in valve-in-valve anatomies.
Yeah.
If you'll ask me, if the size is more than 25 onwards, both the valves will do good. You have to really go with the anatomy, which anatomy fits better, like calcium, raphe, fused and everything, and coronary heights. But valve-in-valve, the self-expandable is definitely upper edge.
Yeah, I'm sorry for the interruption, Mr. Chairman. We have totally run out of time for this presentation. We've got to go with the last presentation.
Can we have one?
Era of amyloidosis. There are 20% of aortic stenosis, especially when the gradient is out of, heart failure is out of proportion to the gradient. Almost 50% of low flow, low gradient is amyloid, cardiac amyloid. Now, all Indians should have data that these 51% of surgically surgically removed valve have some evidence of amyloid. Do you think these patients, in Indian patients, should be evaluated for low flow, low gradient for cardiac amyloid like pyrophosphate scan with red flags?
Usually, whenever we get a discrepancy, the symptoms out of proportion to the gradient and LVH is out of proportion to the valve stenosis, we subject all our patients to cardiac MR and we try to rule out the amyloidosis on those kind of patients. But if you see, even with this low flow, low gradient, and usually subgroup what you are mentioning with the diastolic heart failure more, these are like low flow, high gradient sometimes because of the good contractility. So these kind of patient, even if you treat them with valve replacement, they benefit. That is what most of the trials and most of the studies have shown. If you don't treat them, they are more worse. And if you see, even if you subject those patients for surgical aortic valve replacement, surgeon land up with putting a smaller valve and there is a more significant patient prosthesis mismatch, and post-surgery, these patients do more worse compared to tower valves. So I think these patients, whatever may be the symptom and whatever may be the hypertrophic, and even there is the overlap between amyloidosis and aortic stenosis, they should be offered a therapy and they will get benefited without any doubt.
That's all the time that we have, Mr.
Thank you so
Chairman.
much for your patient hearing.
Thank you, Dr. Suman, Center and Research